This session is on Young Investigators Workshop, combined APASLAASLD and ASLD. My name is Dan Yook Young. I'm from Singapore, and it's my pleasure to have Professor Iwakiri as a co-chair. Introduce yourself.
Hi, I'm Yasuko Iwakiri from VA University.
Okay, can I just check if Dr. Nipun Verma is here? Okay, if not, then what we'll do is we will push forward the schedule and we will invite our next, the second speaker to start off with today's session, Dr. Pruksa Ananchusuk from Thailand. Our topic today is on the ALBI grade and platelet count to predict high-risk varices in hepatocellular carcinoma. Dr. Pruksa.
So, good afternoon, Chairman and everyone. Thanks for the opportunity to present my research, modify RB grade and platelet count to predict high-risk varices in patients with hepatocellular carcinoma. So I have nothing to declare for this study. Okay, let's begin with the background. The occurrence of variceal bleeding in HCC patients was significantly associated with mortality, and previous data has shown that primary prophylaxis, either with EVL or beta blocker in patients with high-risk varic in HCC patients, improve survival. Therefore, to predict high-risk varic in HCC patients, it's essential to indicate the prognosis and also provide prompt intervention. Currently, the Room11 criteria promote non-invasive tests to identify portal hypertension and also recommended endoscopy for variceal screening in cirrhotic patients with liver stiffness by transient elastography of more than or equal to 20 kilopascal or platelet count less than or equal to 150,000. However, the study using Room11 criteria to detecting high-risk varic in HCC patients receive conflicting results. Therefore, right now, there is no recommendations of to select the patients to do the endoscopy in HCC patients. The albumin bilirubin score or ALB score predicts survival and assess liver function in HCC patients and has been mentioned in the Barcelona 2022 guideline. Previous studies studied the combinations of ALB score and platelet count by calculated from ALB grade, part 1 point for platelet more than 150 and 2 points for platelet count less than or equal to 150, and found that this score demonstrates the good diagnostic performance to predict high-risk varic in HCC patients and showed an excellent negative predictive value of 98.1% to exclude high-risk varics in HCC patients. Therefore, our study aimed to validate and refine the previously studied albumin, bilirubin, and platelet score for predicting high-risk varic in HCC patients. Next is about a method. We retrospectively include patients with HCC and had EGD report at King Chulalongkorn Memorial Hospital, Bangkok from 2019 to 2023. Patients with prior GI bleeding were excluded. High-risk varic in our study was defined as F2 or FT varices on EGD report. The liver function test and platelet count were retrospectively document that we choose the nearest one to the EGD and not more than 6 months before EGD. The ALB score was calculated as shown in the slide. The ALB grade and modified ALB grade were classified as shown in the table. We calculated ALB platelet score according to previous study from Chen et al. And our study proposed the modified version of ALB platelet score by calculated combine 1 point from modified ALB grade 1 or 2A or 2 points from modified ALB if patient have modified ALB grade 2B or 3 plus 1 point from platelet count as shown in the slide. We use standard statistical analysis for this study. Next is the results. Of 564 HCC patients, 277 patients with EGD results were included in our study. The characteristic of enrolled patient is shown in the table. Most of the patients are male, about 80%. The mean age is 66.42. Most of our patients have cirrhosis type A, around 90%, and there are 47.3, 30.7% and 22% of patients with HCC Barcelona staging A, B, and C, respectively. The mean platelets count of all patients is 167,000, and the mean LB score was minus 2.38. There are 38 participants with high-risk variants in our study. The mean platelet count in patients without high-risk variant is significantly lower, and the mean LB score in patients without high-risk variant is significantly higher compared to patients with high-risk variant in our study. On multivariate analysis, the modified LB grade 2B and 3 and platelet count less than 150,000 is significantly associated with high-risk variants in HCC patients with an odds ratio of T.49 and 3.92, respectively. The area under the ROC curve of LB score and platelet count for predicting high-risk variant in patients with HCC. The LB score show AUROC of 0.755 and platelet count show AUROC of 0.738. Next section, we're going to discuss about LB platelet and modified LB platelet score. Of entire cohort, there are 28.5% of patients with LB platelet 2 and 36.8% of patients with modified LB platelet score of 2. And as you may see in the slide, the higher proportion of patients without high-risk variant has LB platelet or modified LB platelet 2 compared to patients with high-risk variants. This slide shows the sensitivity, specificity, positive predictive value, and negative predictive value of platelet count, LB and modified LB grade, and LB platelet and modified LB platelet score at each cutoff for predicting high-risk variants in HCC patients. Combining LB grade and platelet count show the excellent diagnostic performance for predicting high-risk variant in HCC patients. Both LB platelet and modified LB platelet at cutoff 2 show the excellent sensitivity of 97.4% and 94.7% and receive the comparable high negative predictive value of 98.7% and 98%, respectively. To summarize, high-risk variant was significantly associated with modified LB grade 2B and 3, and also platelet count less than or equal to 150,000. The area under the curve of LB score and platelet count for predicting high-risk variant were acceptable. And LB platelet and modified LB platelet at cutoff 2, which equal to patients with LB grade 1 or 2A and platelet more than 150 show excellent diagnostic performance. For LB platelet score of 2, it's received negative predictive value of 98.7, and for modified LB platelet 2, it's received negative predictive value of 98%. Our study have several limitations due to the retrospective nature, and our study is the tertiary care center, so only 36% of enrolled patients being new case. However, actually it's present the real-world situation of HCC clinics, which have mixed new and treated patients. So I think this score can be applied in real-world situations. And secondly, there is a gap between lab value and EGD. However, the median duration between them is only 13 days, so I think it's not affect the lab change during this time. So, in conclusion, modified LB grade and platelet at 150,000 showed significant association with high-risk variant in HCC. And moreover, our study proposed that HCC patients with modified LB grade 1 or 2A and platelet count more than 150,000 may avoid AV surveillance. Thank you for your attention, and I will be delighted to answer to the question.
Thank you. Is the floor open to the floor for any questions and comments?
Very interesting observation. So, being a basic science, probably I will ask you some maybe off question, but why you started to look at albumin platelet ratio for this study? What is the significance of looking at those values?
Yeah. For platelet count, it reflects the portal hypertension in patient with cirrhosis and maybe in HCC. And also, LB score reflects the liver reserve in patient with HCC. Previous study used non-invasive tests, including transient elastography, which may be confounded by tumor. But I think LB score, which calculated from albumin, bilirubin, and platelet, is not affected by the tumor at all, and it's an easy tool to calculate that even in the center that have limited resource. So that's why I'm interested in this score.
I see. Can I ask one more question related to your answer? So are there any direct relation to the platelet or platelet phenotype to the HCC progression and so on?
That's the interesting question. Yeah, from my literature review, I found some research that talk about platelet type and also even distribution wide of the platelet that related to the HCC and also portal hypertension. However, because of the retrospective nature of our study, we don't have those data, so that's why we didn't analyze that. But in the future, if there is further analysis, I think it could be the good research question.
Thank you.
Yeah.
So thank you for a very clear presentation. So I noticed that you recruited this patient from your HCC clinic.
Yes.
So, how extrapolatable is this to the regular general cirrhotic clinic?
All of the enrolled patients had HCC, and if you look at the baseline characteristic of the patients, first, most of our patients, actually all of our patients is compensated. Around 90% is cirrhosis type A, and about 10 to 20% is type B. So first, I think it can be applied in compensated cirrhosis patient. Secondly, we validated in patients with HCC with in our entire cohort, we include all staging. So I think it can be applied to all.
Did you have a chance to validate this in the non-HCC patients?
No. However, from my literature review, there are 2 studies in cirrhotic patients, and it found an excellent diagnostic performance as well.
In the patients who had a portal vein thrombosis due to HCC, did you notice whether they still followed this correlation, or because their portal hypertension was the pathophysiology is different? Yeah.
Actually, there are 71% of patients with portal vein thrombosis, which account for only 10% of patients in the study, and I have do the univariate analysis, and it found non-significant associations with HCC. So I'm not sure whether it's because of the small number of patients or because it's not associated.
One more last technical question. This was a retrospective review of the endoscopy pictures. How many endoscopists were involved in this study in your center? And do you have a standardized protocol for collecting pictures? And if you did any measures to control for the reliability or reproducibility of interpretation of your staging for varices?
Okay, so Actually, in our center, the endoscopists are both trainee and faculty. However, in our study, we review the picture of the varices as well to confirm that it's F2 or F3 or F3. Yeah.
Did you also, maybe last one, do you have a chance to also look at the high risk with red whale sign and so on, besides just the F2, 3 size, but high risk stigmata?
I didn't collect that data. Yeah.
Any other questions from the floor? Okay, if not, thank you very much for the presentation.
Thank you.
So our next speaker, which you probably won't find it in your book, is Dr. Ho Agnes Yu Yen. Her topic is on the effectiveness of non-selective beta blockers on preventing hepatic compensation and mortality in hepatocellular carcinoma.
Good afternoon. Thank you for having me here to present my findings of the study on the effectiveness of non-selective beta blockers in preventing decompensating hepatic events and mortality in patients with hepatocellular carcinoma. So just to introduce myself a bit, I'm Dr. Agnes Ho from the Prince of Wales Hospital of the Chinese University of Hong Kong. I don't have anything to declare for this study. So to start with, as you all know that clinically significant portal hypertension, defined as more than 10 mmHg of the hepatic venous pressure gradient, is a significant and critical stage beyond which liver-related complications arise, including the ascites, variceal hemorrhage, hepatic encephalopathy, spontaneous bacterial peritonitis, and hepatorenal syndrome. Meanwhile, non-selective beta blockers have been known for a long time of its effectiveness in reducing the portal pressure, making it the gold standard of variceal bleeding prophylaxis, no matter primary prophylaxis or secondary prophylaxis for many years already. In the recent years, there are numerous studies to support that because of the pathophysiology and the mechanism of reducing the portal pressure, non-selective beta blockers are also effective in reducing the risk of hepatic decompensation in patients with clinically significant portal hypertension. So our study targets mainly on patients with HCC, in which this is a group of patients where most studies actually exclude them when studying on the non-selective beta blockers in preventing hepatic decompensation. But we see there are a few important reasons for us to focus on this group of patients. So first of all, hepatocellular carcinoma is a global health issue because of its high incidence and also low survival rate, in which hepatic decompensation also plays a very important role in HCC. The liver function reserve is a crucial prognostic factor, and hepatic decompensation is also the leading cause of HCC-related mortality. Patients with hepatic decompensation also have limited treatment options, including, for example, liver resection. Apart from that, the pathophysiology of developing portal hypertension in patients with cirrhosis are quite different from patients with HCC. In HCC, the portal hypertension increases mainly because of the presence of arterial venous shunting within the tumor, also because of the change in liver architecture due to the presence of the tumor, and last but not the least, also due to the tumor invasion into the portal vein and its branches. Not to say that there is a scarce evidence of non-selective beta blockers treatment effect in patients with HCC, as mentioned just now, because most of them are included in the studies, likely because of the high mortality and many confounding factors. Because of the growing evidence in the effectiveness of non-selective beta blockers in preventing hepatic decompensation in patients with compensated cirrhosis, we wonder whether non-selective beta blockers can actually exert similar effects in patients who developed HCC. So that's how our research questions arise. So let's go to the methodology. Our study is a territory-wide retrospective real-world cohort study. Data was retrieved from the Clinical Data Analysis and Reporting System, the CDAS, of Hospital Authority of Hong Kong. Just to give you some ideas what the CDAS is. It's actually a system that covers the electronic health records from all public hospitals and clinics in Hong Kong. So it includes all the patients' demographics, medical history, procedure records, laboratory results, and also medication records. Because around like 80% of the patients actually attend the public hospitals in Hong Kong, so it's actually, the data set is actually representative of around 80% of data from the Hong Kong population. So we identified all individuals who were diagnosed with HCC and had esophageal and or gastric varices from 1st of January 2000 to 31st December of 2020. So there are a number of patients that we excluded from the study population. So this included patients with who were less than 18 years old. So the patients we included were mostly adults, and patients who were pregnant at the time of HCC diagnosis, or if they were co-infected with human immunodeficiency virus, HIV, or if they had liver transplantation in 6 months before the enrollment, or if, because it's a retrospective study from the data set, so if from the data, the date of the death was recorded before the date of HCC diagnosis, we excluded these patients as well. The primary endpoint of our studies is was a composite endpoint of hepatic events, defined as the first or further hepatic decompensation, including ascites, variceal hemorrhage, hepatic encephalopathy, spontaneous bacterial peritonitis, and also hepatorenal syndrome. And our secondary endpoint is the liver-related mortality. For the baseline state, we set today as the date of HCC diagnosis, in which the demographic data, all the lab results, for example, the liver function, the INR, the prothrombin time, the renal function, etc., we collected within the 6 months of the baseline date. We also collected information on relevant diagnoses related to the etiology of the liver cirrhosis, for example, the viral causes or alcohol-related liver cirrhosis, and also collected data on the pre-existing cirrhotic complications and comorbidities. Procedures related to the management of cirrhotic complications, for example, the ascitic drainage, we identify them by the coding as well. And drug information, for example, the chemotherapy received or the beta blockers or the DM medications, etc., were identified the relevant drug code, identified the drug information by the relevant coding as well. So this group of patients were followed until death. So either they had liver-related death or non-liver-related death, or if they have liver transplantation, or till the last follow-up date, which was set to be the date of data retrieval, or till around 5 years of follow-up, whichever came first. So moving to the statistical analysis, we use the SPS and the R software to do the analysis. Cumulative incidence function of the first or further hepatic decompensation with the adjustment of competing death and liver transplantation, and liver-related mortality with the adjustment of non-liver-related mortality and liver transplantation were estimated by Gray's method within 95% confidence interval. So the regression model we used was the cost-specific hazard model, and also after multiple imputation, and it was implemented for the univariate and multivariable analysis. A time-dependent covariate was adopted to model the change in the treatment. So this included the change from non-selective beta blocker users to the non-selective beta blocker users. Also, if they have it otherwise, for example, started with the use of the non-selective beta blockers, but later changed to non-selective, they changed to non-selective beta blockers non-users, we allow this change with the time-dependent covariate. The baseline covariables, the indicator of first or further hepatic decompensation, and the Nelson-Allen estimator of cumulative hazard were included in the imputation model. Covariables included in the multivariable analysis were selected by backward elimination method. All the statistical tests were two-sided. Sorry for the typo here. And the statistical analysis was taken as the p less than 0.05. And we also performed a subgroup analysis in our study, in which patients with the use of beta blocker, we defined with the duration of the non-selective beta blocker use by 90 days. So either they use more than 90 days or no or less than 90 days for this subgroup analysis. So let's go through the results. So we identified total of 5,898 patients in total. And after excluding the 444 patients according to our exclusion criteria, we eventually included 5,454 patients in our cohort, in which 77% of them were non-selective beta blocker users, and 23% of them were non-selective beta blockers non-users. And around 20% of them had already had the first hepatic decompensating events before the recruitment. So this is just a table showing you the baseline clinical characteristics. And because of the time constraint, I'm not going to go through very deeply. Just that the mean age of all the patients in the two groups was around 60 years old, while most of them are male, and most of them had viral cause of cirrhosis. And the group between the users and non-users of the non-selective beta blockers, they have similar severity of cirrhosis by the Chabot class. To look at our first primary outcome first, which is the first or further hepatic decompensating events, the 1, 3, and the 5-year cumulative incidence of the events were respectively 26%, 38%, and 44%. Patients who used non-selective beta blockers had a trend towards a lower risk of developing the first or further hepatic decompensating events. By doing the subgroup analysis, our group actually showed that for patients who had used at least 90 days of non-selective beta blockers, they had a significantly lower rate of hepatic decompensating events than untreated patients. And then those who received non-selective beta blockers of less than 90 days, with the cumulative hazard ratio at 0.88. For the liver-related mortality, the 1, 3, and 5 year of liver-related mortality were 36.1%, 52.8%, and 60.6% respectively. For further analysis, we showed that the use of non-selective beta blockers did not have significant impact on the liver-related mortality. So as if you use the longer duration of non-selective beta blockers, there may be a trend of having a lower rate of liver-related mortality. So because of the time constraint, I'm not going too deep into the discussion and limitation of my paper. But just to conclude, in our study, we did not demonstrate a significant impact of non-selective beta blockers in reducing liver-related mortality in patients with HCC. But patients with who used patients with HCC who used non-selective beta blockers, there was a trend towards a reduction in first or further decompensating events. And this effect was significant if they used the non-selective beta blockers for at least 90 days. So I think the message behind is that if we want to use the non-selective beta blockers to give a significant impact on reducing the first or further hepatic decompensating events, we may have to consider a continuous use for a longer time instead of frequent interruption due to events, for example, like a low blood pressure, we just interrupt and then we stop it forever. It may need some time for the non-selective beta blockers to exert its effect. So this will be the references that I used, and thank you so much for your attention.
Thank you.
Thank you.
We open to the floor for any questions.
Okay.
Yes, please. If you'd like to just maybe come to the microphone and just share your name and where you are from.
So thank you very much for a very interesting presentation. I have two questions. First of all, you speak of non-selective beta blockers. Did you look at the difference between propranolol and carvedilol, or what were the options in your study? And the second, you talk about a composite endpoint, so all types of decompensations. Do you think there might be a difference there, or just lumping them together might hide an effect? Do you think non-selective beta blockers theoretically protect against all sorts of decompensations? For instance, jaundice in a retrospective study can mean many things. Thank you.
Thank you. Thank you for the fantastic question. So for your first question, we included patients with both propranolol and carvedilol in our study, because in the past 20 years in Hong Kong, they were the most used beta blockers in the public hospitals in Hong Kong. However, we grouped them together for the analysis because the carvedilol users was a much smaller group of patients, mainly because this drug was it was just maybe in the recent years, it was introduced to the use in the public hospitals in Hong Kong. And the second reason for its more number, I think maybe because that it's only very recently there were studies to prove that carvedilol actually has a much better effect than propranolol to prevent the hepatic decompensation, and a much stronger effect in reducing the hepatic venous pressure gradient. And in previously, clinicians or physicians, they actually prefer the use of the older generation propranolol. So that's why we group them together instead of doing the analysis separately, because it makes the results much underpowered. And then for your second question, in our analysis, we group all the hepatic decompensating events together because because of during the analysis, we realized that for some of the decompensating events, for example, the hepatorenal syndrome, it was much less coded in the system. So, which makes the interpretation difficult. But I agree that it may be useful to separate them into small groups to do the analysis to see the beta blockers effect as well. We may do it when it comes to our full paper as well. So thank you so much.
So congratulations on your great presentation.
Thank you.
My question is, do you have the separate the responder and non-responder to beta blocker in your study? For example, do you have the data of heart rate or blood pressure after studying beta blocker of enrolled patients?
Thank you for the question, and it's a very important concept when we use the non-selective beta blockers. I think it's one of the major. I think it's one of the things to consider to include whether the patient is responsive or non-responsive to the non-selective beta blockers. But we didn't do that in our study, mainly because from the and it's definitely, I agree that it's a flaw. But first of all, we do not have the measurements of the HVPG, this invasive monitoring in our routine practice. And the other thing is that because from the blood pressure and the heart rate, it is also not available in the CDAS system as well. So the entry is not complete. So we didn't really record, we were unable to retrieve this piece of information fully. So,
Thank you.
I think a prospective study will be helpful.
Thank you.
Thank you.
Thank you. So thank you for your presentation. So following up from the last question of determining who the responders and non-responders, you have used 90 days as a surrogate for that efficacy rather than compared to no efficacy. Would you postulate what's the biology, or is there any data supporting why a 90 days longer duration effect would make a difference to your portal pressure?
Thank you for your insightful comments. And we actually try to analyze 30 days or 60 days, 90 days, and it comes back to be we found to have a better effect with 90 days, but I don't think there is any study that is very well established on the duration of the use of the non-selective beta blockers in preventing the hepatic decompensation so far as I know.
The second question is on, again, similar to the original question from the floor, looking at the different decompensation or even the cause of death, were you able to determine the relationship between liver-related mortality, non-liver-related mortality, for example, cardiovascular mortality?
Yes, we actually did analyze on the liver-related and non-liver-related mortality, but we didn't really go too deep into the cause of the non-liver-related mortality, just separate into these two groups. But there was no significant effect of the non-selective beta blockers on both liver and non-liver-related mortality.
Right. As you know, there is a little bit of bad press about beta blockers in decompensated cirrhosis when your child, especially child C blood pressure is low, systemic blood pressure is low. Did you see this J curve in your cohorts, or did you withdraw the child C from your analysis?
We included patients with child Cs as well, but I think it's worth to go back to see the analysis again. But as far as I remember, I don't really see this kind of effect in our study, in our analysis.
Last question on this. So again, this is a group of liver cancer patients. In your first slide, you also mentioned that liver cancer does distort your portal hypertension.
Yes.
Did you have enough numbers in each of these subgroups? Portal vein thrombosis versus no portal vein thrombosis, and therefore were there a difference in your subgroup analysis?
Thank you for this question. So I think for the portal vein thrombosis, it's actually a very important cause of the increase in the portal pressure in this group of patients. But we didn't really, weren't really able to get a very complete differentiation in patients with or without portal vein thrombosis, mainly because of the coding problem, and because of the in general, actually from the literature, over half of the patient will have portal vein thrombosis if they have HCC. So we didn't really separate them into the groups because of the clinical practice issue on the non-selective beta blockers as well.
Okay. Okay, if there are no further questions, thank you very much for the presentation.
Thank you.
Thank you. Can I check one more time if the first speaker is on site, Dr. Nipun Verma? Okay. Okay. Okay, if not, then there will be only two speakers for this particular session. I think we will call this session to a close. The next session will be at 14:10 for the next group of speakers for Cirrhosis 2 session. Thank you very much for everyone, and have a good afternoon. Okay.